for oxygen and critical care today. Our lead panelist today, we're very excited to have Dr. Anna Maria Crawford, as usual, and with her, we have Dr. Rediot, Dr. Andrea, Dr. Grant, Dr. Justin, and Dr. Maria Quincy. So excited to have our panelists today. So just a few echo etiquette and housekeeping reminders before we get started. Our programming is based on a foundation of love and respect, so please respond kindly rather than react if you disagree with something. It is everyone's responsibility to keep the webinar a safe space. We will be using the chat function for Q&A, which is at the bottom of your screen. So please send all questions through the chat box and feel free to introduce yourself there. We'd love to get to know you. Please turn on your video if you're able to. Position your webcam effectively to show your face if you're alone, or to capture the whole group if you're with people. If you have IT issues, send a message through the chat box. This session is being recorded and your attendance is consent to be recorded, so thank you. And finally, please be mindful of infection prevention and control. Try to limit the number of people joining from one gathering place and practice physical distancing. And with that, interpretation. If you need interpretation, we do have French and Spanish interpretation available. So at the bottom of your screen, there's an interpretation button. You do need the new version of Zoom for this to work. So you can choose to mute the English part of the session, or you can listen to both. But once you click on that interpretation box, you can select which language you'd like to listen to, and the translation will be louder than the speaker. If you have any questions about that, again, please feel free to ask questions through the chat box to our IT support. So now we will turn it over to Dr. Anna Crawford to begin our session.
Hello, everyone. Thank you for joining. Happy to see you all again. I'm going to share the screen, and as per usual, we're going to use the Learning Resource Center to go through the case-based discussion. So the case-based discussions can be found within the Oxygen Series course on the Learning Resource Center. And in Oxygen Therapy and Critical Care, you can click on that and go down to Part 9, Pediatric Considerations for Oxygen and Critical Care. Okay, so today we're going to be discussing a 6-year-old who presents with wheezing and increased work of breathing, or the pediatric considerations for oxygen and critical care. I'm going to close this side navigation pane so that we can see the entire screen. We do want to start with our disclaimer and our pledge to our learners. We are here to help providers make the best decisions for their patients, but we want to remind participants that discussions in the content of the LRC serve to promote exchange of knowledge and experiences of healthcare providers. These discussions are in no way intended to substitute for clinical judgment and independent decision-making of qualified healthcare professionals. Administrators of the Learning Resource Center make every attempt to provide up-to-date and accurate information. However, we all know that information changes rapidly. Individual healthcare providers are responsible for adapting information to fit the availability of resources and standards of care within their own institutions. And we pledge to our learners that we believe education should be free and free of conflicting interests. The Learning Resource Center aims to bring high-yield, evidence-based, and peer-reviewed resources to learners, regardless of resource setting. We pledge to keep education open access and free. We also pledge to keep education free from advertising. We want to uphold ethical standards, and we pledge to approach all learners with compassion. Assist International is an international nonprofit organization, and the Learning Resource Center received no financial compensation or advertising incentives other than within these partnerships. So with that, I think we need to set the context of the case that we're discussing today. Pneumonia is the leading cause of death in children under 5 years of age. And according to the World Health Organization, every year over 5.9 million children die, mostly from preventable or easily treatable diseases. More than 95% of those deaths occur in developing countries. Pneumonia is the leading cause of death in children under 5, being responsible for at least 18% of all deaths in this age category. In 2010, there were an estimated 120 million episodes of pneumonia in children under 5 years. 14 million progressed to severe disease, and 1.3 led to death. 3 million led to death. Hypoxemia, something we'll be discussing today, which is insufficient oxygen in the blood, is a major fatal complication of pneumonia and increases the risk for death many times. It is estimated that 13.3% of children with pneumonia have hypoxemia, corresponding to 1.86 million cases of hypoxemic pneumonia each year. Further, 23% of the 5.9 million annual child deaths result from neonatal conditions such as birth asphyxia, sepsis, and low birth weight, all of which can lead to hypoxemia. These add to the substantial burden of hypoxemia, especially in developing countries. This statement was written before the pandemic, so we expect these numbers to actually worsen. And there are several low and middle income countries that are considered double burden countries, where they're suffering from high numbers of COVID-19 and child pneumonia. Today in our case-based discussion, we have some practice change objectives. We like to call them practice change objectives instead of learning objectives, because we want this information to actually be used to improve your practice in taking care of patients. So the first is to know the various oxygen supply options for various pediatric healthcare settings. The second is to know the various oxygen delivery devices that are available for use in pediatric patients. Learners should recognize the safe SpO2 goals for various pediatric patients and conditions, and learners should understand and treat the pathophysiologic conditions that lead to hypoxemia in pediatric patients. Learners should be able to recognize hypoxemia during the clinical exam of pediatric patients and understand the diagnostic considerations for pediatric patients with hypoxemia. They should also appropriately prescribe oxygen therapy and implement appropriate therapeutic options for pediatric patients with hypoxemia. So these are our practice change objectives, and we will revisit them throughout the case discussion. And with that, I'd like to turn it over to our case moderator, Dr. Andrea Murray.
Good morning, everyone. So excited for you all to be here and look forward to learning with you as we go along. So to jump into our case, today we will be doing kind of a problem-based learning format as in previous webinars. Today we have a 6-year-old male with no significant past medical history who presented to the emergency department with wheezing, increased work of breathing. His symptoms started approximately 12 hours ago, and he has been less active for the past 24 hours per his mother's account. His mother also describes that for the past 5 days, he's had fever with a maximum of 39.3. He had a respiratory viral panel and a rapid SARS-CoV-2 test 2 days ago, and both were negative. At the time of his respiratory panel and SARS-CoV-2 test 2 days ago, he had no respiratory symptoms. However, his mother had redness and swelling of his hands and his palms. She also reports that today his eyes seem to be swollen. The patient's aunt lives in the same house and had COVID-19 3 weeks ago, but her only symptom was anosmia. His birth history was not very significant. He was born at 32 weeks, a bit early due to severe preeclampsia, and spent 4 weeks in the NICU, mainly to feed and grow, but no interventions were necessary. He has no other past medical history. Surgical history, he had his appendix removed in 2019. And he lives at home with his parents, grandparents, paternal aunt and uncle, and the aunt with a recent COVID. His vaccinations are up to date, except for yearly influenza, which has been decreased due to clinic access from the pandemic. He does not take any medications and he has no allergies. So at this point in time, I'm going to turn it over to Dr. Shamilis, who will discuss oxygen supply. And our practice change objectives for this is to know the various oxygen supply options for various pediatric healthcare settings.
Okay. Hello, everyone. Hope you're able to see me right now and hear me well. I'm excited to be here with you all and learn from your experience as well. So today we'll be discussing oxygen sources. So let me just directly go to the questions. As Dr. Andrea has already mentioned the practice change objectives, I would expect for all of you to list 4 sources of medical grade oxygen in your setting or any medical care oxygen that you know, and write it down in the chat box. And how do the 4 sources of oxygen differ from each other? Please, I'll give you about 45 seconds to write it in the chat box, what sources of oxygen you have or you know exist. Thank you. So you can write it in the chat box. Right, we have great answers coming in right now. I'll wait for most of our participants to finish. So any difference between, most of you have mentioned different types of oxygen sources. Can you mention the differences? So great answers coming up. Just mention some of the differences among the different oxygen sources.
Ready?
And
do you
also
want to go to the resource?
Okay.
The table? Okay.
Can you, Anna, would you be able to project what's projected on my slides? Is the
Yes, I'm working on it. Sorry.
Okay.
Yeah.
Thank you.
So
Sorry.
For the learners, we are going to use the WHO UNICEF technical specifications and guidance for oxygen therapy devices to find the answers to those questions. So we're going to go to page, it's page 17 in the.
Yeah, so everyone, great answers. So most of you have mentioned the different types of oxygen sources. We've got cylinders, we've got concentrators, oxygen plants, and liquid oxygens. So some of you might have some of them and some not. So we'll try to see the differences, the pros and cons. So oxygen cylinders, can you go down a little bit, Anna, on the table, just to discuss the definition of each? The table that's projected, is it? Yeah. Can you go up, I mean, yes. Yes, so we've got here oxygen cylinders. These oxygen cylinders are a reliable cylinder storage vessels used to store and transport oxygen in compressed gas forms. Anna, would you not make me an admin? Many people are waiting in the waiting room, so that is on my screen. A co-host, can you not make me a co-host so that's not projected on my screen? Yeah, thank you. So oxygen cylinders, sorry about that, everyone, are a reliable cylindrical storage vessels used to store and that are used to store oxygen in compressed gas forms, and cylinders are refillable at a gas generating plant, and thus they require transportation to and from a plant. So this is described. So I'm going to go through the different parameters of the different types of oxygen sources, the oxygen cylinders, the concentrators, oxygen plants, and liquid oxygen. So when it comes to oxygen concentrators, they are well-contained, electrically powered medical devices designed to concentrate oxygen from ambient air using PSA technology. And these oxygen plants they are oxygen generating system using PSA technology, which supplies high pressure oxygen throughout a facility and a central pipeline system, or via cylinders refilled by the plant. When it comes to liquid oxygen, these are bulk liquid oxygen generated off-site and stored in a large tank and supplied through a health facility via a central pipeline system tank. It requires refilling by liquid oxygen supplier. So that is their description. So when it comes to clinical application, most of these can be applied in different settings. Cylinders can be applied to different levels of healthcare facility. It can be used for oxygen, all oxygen needs, including high pressure supply, and in facilities where power supply is intermittent or unreliable because it does not require electric sources. And when it comes to concentrators, it can be used to deliver oxygen at the bedside or within a close proximity to a patient areas. And a single concentrator can service several beds with different flow meters and divide among patients. When it comes to oxygen plants, it can be used for all oxygen needs, including high pressure supplies. And liquid oxygen, it can be used for all oxygen needs, including a high pressure supply in facilities where power supply is intermittent or unreliable, as it does not require electric sources. So cylinders can be applied in almost all health medical systems. Concentrators, primary and secondary, possibly tertiary as well, they can be used in that kind of healthcare facilities. And the oxygen plants can be used in a secondary or tertiary level, or they are relatively more advanced. And liquid oxygen definitely in secondary and tertiary, as it's very advanced and requires higher technology. And you kind of go, yeah, yes, thank you. When it comes to distribution mechanism, cylinders are connected to manifold of centralized high central pipeline distribution system, or directly connected to a patient with flow meters and tubing. And concentrators are directed to patients with tubing through flow meters. And these are some of the things that we know already, so I'm not going to go too much on it. But oxygen plants and liquid oxygen are central sources, usually subcentral central sources, where you connect them to a bedside and distributed system, or can be used to refill cylinders that can be connected to a manifold system in the facility. When it comes to electricity use, I've already mentioned that cylinders do not require cylinders and liquid oxygen, but concentrators do require it. And also when it comes to cost considerations as well, the initial cost is relatively moderate for oxygen, cylinder oxygens, and also the same for concentrators, but it's very high for liquid oxygen and oxygen plants. When it comes to ongoing costs, it's relatively high for oxygen cylinders because they need to be refilled, need to be retransported from and to the institutions. And when it comes to concentration, they are relatively lower costs. Oxygen plants and oxygen plants as well, they have relatively lower or moderate costs, ongoing costs. And the same for liquid oxygen as well. But maintenance requirements, small degree of maintenance is required for cylinders, but some degree of maintenance is required for concentrators, and significant maintenance of systems and preventive maintenance is required for oxygen plants and liquid oxygen. They are high-tech requirements. So when it comes to user care in oxygen cylinders, it's about moderate, regular checks of filterings and concentration. That's about the cleaning of exterior that's really needed. And when it comes to user care, not much really. And the same for concentrator, it's moderate cleaning of the exterior. And the tubing can be something that needs to be required. And for oxygen plants, it's very minimal at terminal unit only. But for oxygen cylinders, the same minimal at terminal unit only. So what are the merits of these different sources of oxygen? Oxygen cylinders are transportable. They don't require electricity. That's a very the good merits of oxygen sources, that they don't require electricity. When it comes to concentrators, continuous oxygen supply It requires it's a continuous oxygen supply if power is available at running cost. So if you have electricity running, it's a continuous oxygen supply source, so it's good.
Apologies, Dr. Reddy, our interpreters are having a little bit of trouble. If you could just speak a little bit slower and a little bit louder, that would be really helpful.
Okay.
Thank you.
I'll be slower. Okay. So concentrators have good merits in terms of continuous oxygen, supplying a continuous oxygen, being a continuous oxygen supply, especially if there is power available. And the output flow can be split among multiple patients. So it can be divided if you have one concentrator using different flow meters, you can divide it among patients. These are the advantages of having concentrators. And when it comes to oxygen plants, it can be cost effective for large scale facilities. You can easily refill cylinders and it's a continuous oxygen supply. So these are the benefits of having oxygen plants nearby. When it comes to liquid oxygen, you get 99% oxygen from it, and it's a high oxygen output for a small space environment. So what are the drawbacks of these different types of oxygen sources? Oxygen cylinders, they require transportation. Actually, this is a drawback. Yeah, they do require transportation, which is extra cost and risky as well. For during transportation, accidents can happen. There is a risk of gas leakage, a risk of fire. Actually, I have witnessed that during my practice, and the risk of unwanted relocation. It can fall on healthcare providers as it is mobile as well. When it comes to concentrators,
Dr. Reddy, I think it's interesting when we talked about the oxygen cylinders, you mentioned that being transportable is both a merit and a drawback, to which I agree, because cylinders can be moved. You can use them in patient transport, in the recovery room, in ambulances, et cetera. But they do have some safety considerations. You break and become projectiles and they can catch on fire, which is, and they can be heavy for someone to carry. So those are all things to consider.
Thank you, Anna. That's exactly the point I was trying to make. I have had friends, for example, break their some of their bones when it fell on their feet. I have witnessed gas leakage and fire, and you know, it requires some professionals. They need to be very careful when handling this cylinder. Since it's mobile, it has its own demerits as well. That was, thank you, Anna, for that.
The official recommendation is to actually have the cylinders secured at all times, whether they're strapped to the wall or in a specialized transportation device, if possible.
Yeah. Yes, thank you. So when it comes to concentrators, they are low pressure output devices, usually not suitable for CPAP or ventilators. So you use flow meters attached to them, and it requires uninterrupted power. So this drawback, it's a drawback because you cannot use it in a place where there is no electric power source, or if there is any interruption, you have to discontinue using it. And it requires a backup. So cylinders are usually a backup for many of these sources that require electricity because they don't require electricity. But concentrators, they do require a backup oxygen source, usually cylinders. And does require some degree of maintenance as well, concentrators. When it comes to oxygen plants, they are so high capital investment, so they do require some money, so may not apply to all type of facilities and all types of settings. It requires uninterrupted power. That's also a drawback, which many of us don't have luxury of. And it needs adequate infrastructure. It also requires higher maintenance for piping and requires backup cylinder supplies, as they require electric power supply. Risk of gas leakage from piping system is also there when it comes to oxygen plants. So oxygen, liquid oxygen, it requires transport and supply chain. It's an inexhaustible supply. High maintenance is required for piping. It's also facilities, and it needs adequate infrastructure for it to be set up. It cannot be set up in all levels of health facilities. It requires backup cylinder supply, and because it requires electricity, it requires backup oxygen and backup cylinder supply, and the risk of gas leakage from the piping is also a possibility in this case as well. So this is about it from the, so most of you have mentioned this, most of you have mentioned the types of oxygen cylinders in here. So thank you. So I'm gonna ask each of you again this question: which of the following oxygen sources are available at your facility? If you can launch the poll question, Anna, that would be great. Oxygen concentrators, oxygen cylinders, liquid oxygen tanks, PXA oxygen plants, and so you can choose. So this is a poll question that you can answer. So I'll give you a few seconds. Which of the following oxygen sources are available at your facility? So you can choose as many, which applies to your setting. Do you have oxygen concentrators? Do you have oxygen cylinders? Do you have liquid oxygen tanks or PSA oxygen plants in your institution where you work?
Ready? This is kind of what I expected to see. Most people do have oxygen cylinders, don't they?
Yeah.
The PSA plants and the liquid oxygen tanks are usually at larger institutions. Looks about half people have oxygen concentrators, which is good, but they break down, don't they? So maybe the oxygen concentrators are in the closet because they stopped working. They require a lot of maintenance.
Yeah, most probably, yeah.
Mm-hmm.
They require maintenance, and also, yeah, they break easily. We can see that about 96% of you have said that you have oxygen cylinders. That's very interesting to see.
Great.
Yeah.
Thank you, Dr. Rediet. We're going to go back to Dr. Andrea for a case update.
Okay, so now that we've discussed sources, we'll talk a little bit about the vital signs for the patient. So temperature is 39.3. Heart rate is 135 beats per minute. Blood pressure is 70/32 with a mean arterial pressure of 45, and respiratory rate is 35. O2 saturation is 88% on room air. So we'll go back to Dr. Rediet and discuss oxygen delivery.
So for oxygen delivery, our practice change objective is to know the various oxygen delivery devices that are available for pediatric patients.
Yeah. So what devices are used to deliver oxygen to pediatric patients? You can write this in the chat box. So what devices are used to deliver oxygen therapy to pediatric patients? There's usually oxygen concentrators, nasal prongs, oxygen masks, oxygen hood. Somebody's mentioning, yeah, Nice mentioning. So what devices are used to deliver oxygen to pediatric patients? That's the question. Intranasal prongs, face masks, nasal prongs. So we've got answers coming. Thank you, everyone. Nasal catheters. Nasal prongs, simple face masks. Teresa has mentioned Venturi masks, CPAP prongs and masks, nasal prongs, oxygen masks and hood, CPAP, nasal prongs. So yeah.
Those are great answers. Someone did
Yes.
put in the chat box that it's the same for adults, especially in older children. Are there any oxygen delivery devices, Dr. Reddiot, that you would use in pediatrics but not use in adults?
Yeah. Yeah, I would. I mean, like, and for example, head box, incubator tents. These, most of them, they can be applied to. Sorry about that. But I think mostly in pediatric patients, we use the options that are available to us, nasopharyngeal catheters. But in adults, I don't know. What's your experience like, Anna?
Yeah, I've never placed a nasopharyngeal catheter or a nasal catheter in an adult. Typically, we use nasal prongs, oxygen, and different types of oxygen masks. Similarly, I've never used a head box or incubator tent in an adult patient.
Yeah, so the same here. I've seen nasal prongs and sometimes nasal catheters. We customize in our setup. We customize what we have. Sometimes when we run out of nasal catheters or prongs or oxygen delivery devices, we make them from IV sets and mimic what's like a nasopharyngeal catheter, insert it and tap it with a plaster on patient's nostrils to deliver oxygen. And it serves some purpose when you don't have any other option. So that's just an experience I have. It may mimic it, but it's not actually exactly it. So we have different types of oxygen delivery devices. We've got nasal prongs, nasal catheters, nasopharyngeal catheters, incubator tents, face masks, which you can use. So nasal prongs, there are different parameters that you can use it to. And the flow meter, the maximum flow also varies. For neonates, you should run for about 0.5 to 1 liters per minute. And for infants, you can go up to 2, and for preschool children to 4 liters per minute, and to school children about 6 liters per minute. With nasal prongs, you should be able to achieve a certain oxygenation with maximum oxygen flow of those liters mentioned. So there's some degree of PEEP applied by these nasal prongs. The FiO2 delivered is very important as well. You can achieve a FiO2 of about 45% with nasal prongs, 50% with nasal catheters, 55% with nasopharyngeal catheters. So relatively higher with the nasopharyngeal catheters. It can be a bit uncomfortable for adults. That may be the reason why we're not using it, but for pediatrics, it serves a good purpose, much higher FiO2 than a simple nasal prongs. And the flow, let me go back to that. Nasal catheters, you can set it to 0.5 liters per minute. To infants, 1 liter per minute. In nasal catheters, and in nasopharyngeal catheters, you set it to 0.5 liters. In neonates and infants, about 1 liter. When it comes to head bulks or face masks, you've got retains. So you can use 2 to 3 liters per kg per minute if you have head bulks of oxygen.
Can some of our pediatric panelists explain why we have flow limitations in neonates and infants? For example, with nasal prongs, the maximum flow in a neonate might be 1 liter per minute, whereas in a school-age child, we can go up to 6 liters per minute. Why is that? Why is there a limitation in the flow that we use in different age groups? Maybe Dr. Andrea or Dr. Grant?
Well, partly it's just that the higher flows are just not needed in neonates, and one can conserve oxygen by having lower flow rates. And then also, if the flow rate is too high in a neonate, that could cause barotrauma and actually cause lung damage. And then also in a neonate, giving too much oxygen, especially in a premature neonate, can cause 1, lung damage, and 2, it can cause retinopathy of prematurity, as someone said in the chat box.
Thank you, Dr. Grant. What about gastric insufflation? Is that a risk with higher flows, the smaller the child?
Yeah, for sure.
Yeah.
I agree with Dr. McFadden. You really have to titrate according to the patient's size. And the increase in flow can certainly cause gastric distension, which then causes decrease in FRC because you're having elevation of the diaphragms. And so it really has to be a bit of a balance. And that is definitely a real risk. I always remind people that oxygen is a medication, just like anything else. So bear that in mind.
Okay.
Excellent, thank you.
So thank you, everyone. Yep.
All right. So to resume our case, just an update. Since the patient was last observed, he was placed on oxygen via nasal cannula at 4 liters per minute. And his O2 saturation has now increased to 92% on that 4 liters per minute of nasal cannula. The other vital signs are essentially stable. So next, we'll turn it over to Dr. Genziano, who will discuss pulse oximetry. Now, practice change objectives for this will be to recognize safe SpO2 goals for various pediatric patients and conditions.
Hello, good day, everybody. My name is Justin Genziano, and I am a resident here in New York City. Let's go ahead and start with this following question. Which of the following statements are incorrect regarding oxygen therapy in neonates? This is going to be a multiple choice question. Question or answer A is all infants less than 32 weeks of gestation or weighing less than 1,250 grams, and any who received oxygen therapy should be screened for retinopathy of prematurity at 4 to 6 weeks old. Option B is newborn infants requiring oxygen therapy should have SpO2 targets greater than 88% or less than 95%. Option C is apnea leads to bradycardia, which further reduces oxygen delivery. And then there's option D, neonatal ventilatory support should be administered with bag mask ventilation and 100% FiO2. Remember, you're trying to pick which one is incorrect. Great, looks like we've got some good answers that came in. The correct answer, or the incorrect answer here, is going to be option D. Neonatal ventilatory support should be administered with bag FiO2 of 100%. You should not use 100% a fraction of inspired oxygen when initially resuscitating a newborn. You can start with room air or an FiO2 of 21% for term neonates, and maybe up to 30% for preterm folks. So one of the major things that you want to take home from this, and we're going to be using a WHO document here to review a lot of this, is that there's a very strong recommendation that you use pulse oximetry for determining the presence of hypoxemia and for also guiding the administration of oxygen therapy to infants and children. It's a good recommendation, and if you have it available, you should try to use it. So next, we're going to look at a few questions just to review some of these topics here. The first question, and these are going to be true or false questions. Where pulse oximetry is not available, oxygen should be given to all neonates who have cyanosis or a respiratory rate greater than 70 breaths per minute, or are too sick to feed. Is that true or false? Looks like we're heavily in favor of true. Yeah, that is correct. It is true. So when you have an absence of the ability to measure pulse oximetry, you have to rely on your clinical signs. And so this is relying on them having a cyanosis, so they are appearing blue, or if they're breathing very, very, very fast, or if they are so sick that they can't even feed. So that's when you would want to go ahead and deliver oxygen in the absence of a pulse oximeter. Let's go on and go to the next question. So the next question is, in children living at a high altitude, and that's 2,500 meters above sea level, the normal oxygen saturation is lower than those living at sea level. And a level of SpO2 such as less than or equal to 87% should be used as a threshold for giving oxygen. Is that statement true or false?
This one looks a little trickier, Justin.
Yeah. It's a close race. So it may come as a surprise to some people, but this is also true. People who live at a high altitude develop mechanisms to allow them to function at lower levels of oxygen, because as you go up in altitude, the amount of oxygen available in the atmosphere is a little lower. And so this is reflected in a lower threshold for starting oxygen therapy than you would normally see in people who live at sea level. We're actually going to get to that for the next question. The next question is, for children with respiratory disease living at less than or equal to 2,500 meters above sea level should receive oxygen therapy if their oxygen saturation is less than or equal to 90%. Is that true or false? All right, looks like we have some good answers in there. For this statement, the statement is also true. We generally use the cutoff of 90% as a way to guide oxygen delivery in patients who are living below that high altitude cutoff of 2,500 meters. And the last statement we're going to review here is that oxygen should always be given intermittently, such as every hour or two, and should not be administered continuously in order to conserve oxygen supplies. Is that statement true or false? So instead of running it around the clock, you should just give it every hour, maybe every 2 hours, especially if you need to conserve oxygen supplies. Is that true or false? All right, nicely done. Yes, so this statement is false. Oxygen should be absolutely administered continuously in hypoxemic patients whenever possible. So to review what we had gone over here is that pulse oximetry should be used to detect hypoxemia and to guide the delivery of oxygen. We typically start oxygen therapy in patients who have an oxygen saturation of less than or equal to 90%, although that threshold is a little lower in patients who live at a higher altitude, with the threshold being at 87%. And we should try to deliver oxygen therapy continuously if possible. So let's go ahead and check back in with Dr. Murray for another update on our case.
All right, thank you. So our patient remains tachypnic and with nasal flaring, intercostal retractions, but slightly improved. SpO2 is stable at 92% on 4 liters per minute nasal prongs. Differential diagnosis is very broad for the presentation of our patient and can include all of the following: asthma, reactive airway disease, foreign body aspiration, bronchiolitis, bronchitis, COVID-19, pneumonia, upper respiratory infection, vascular ring, congestive heart failure, multi-system inflammatory syndrome in children, cystic fibrosis, mediastinal mass, tracheoesophageal fistula, primary ciliary dyskinesia, laryngeal malacia, and gastroesophageal reflux, as well as obstructive sleep apnea. Some of these will definitely be lower down on our list, but initially the diagnosis And the differential for that is very, very broad in this patient. So next we're going to talk about pathophysiology. And the practice change objectives regarding that is to understand and treat pathophysiologic conditions leading to hypoxemia in pediatric patients.
All right. So hello again, everybody. Off with a little bit of a brainstorm and think about 4 diseases of hypoxemia in neonates. You can go ahead and use the chat box to try to think of some things. And remember, specifically looking at causes of hypoxemia in neonates. We got folks saying respiratory distress syndrome, congenital heart disease, pneumonia, neonatal asphyxia, sepsis. TTN stands for transient tachypnea of the newborn or the neonate. Bronchiolitis. Ooh, an aspiration. It's a good one. Cerebral hypoxia. Lots of respiratory distress syndrome.
These look like good answers, Dr. Justin.
Yeah, really great answers. Aspiration, encephalopathy. Yeah, so these are all excellent answers. Some of there are obviously, as we can all see, a lot of conditions that can lead to hypoxemia in neonates. The ones that might be the most common in neonates are respiratory distress syndrome. That's when the baby is born a little on the early side and hasn't developed enough surfactant to keep those lungs open right after being born. There's also the transient tachypnea of the newborn or the neonate. That sometimes happens when the neonate has extra fluid in its lungs and can't exchange gases as well as they normally do. Pneumonia is also very common. Meconium aspiration is another common cause that's associated with neonatal hypoxemia immediately after birth, especially if it was a stressful delivery. If the neonate is unwell for other reasons, like they're premature, they have a concern for sepsis, seizures, hypoglycemia, then the neonate is also prone to apnea. When you have apnea, again, their respiratory rate is very low or non-existent, so they can't exchange air and they can't get oxygen into the lungs and into their bloodstream. Little babies that are prone to apnea, if they're otherwise well, if they're very small when they're born, less than 1.5 kilograms, or if they're born early and have a gestational age less than 32 weeks. So apnea and hypoventilation are causes of hypoxemia that can lead to a slow heart rate, as we remember earlier in the pulse oximetry section, that further reduces your oxygen delivery to tissues. So nicely done, everybody. How about moving on to a slightly older children? Does our differential change when you think of hypoxemia in older children? What do you think of as causing hypoxemia for children? Go ahead and brainstorm again, and we'll put some answers here in the chat. Yes, pneumonia across the board, asthma, bronchiolitis, aspiration, foreign body aspiration. We all know kids love to stick things in their mouth, so they accidentally inhale it. RSV, that's a respiratory syncytial virus, is a big one. Yeah, congenital heart defects, anemia, where their amount of red blood cells is a little low. Pneumonia again, foreign body aspiration. Great answers. So when we think about hypoxemia, and again, we're referencing this WHO document. Oh, cystic fibrosis, that's another very good one to keep in your mind as well. Hypoxemia in older children is by and large caused by infections that cause pneumonia and bronchiolitis. These are typically caused by bacteria like Haemophilus influenzae or E. coli, but can also be caused by viruses like the flu, RSV, or as we all are very acutely aware of these days, coronavirus. Other causes that may be on your differential for children include asthma, so a reactive airway, meningitis, sepsis, aspiration, congenital heart disease, cystic fibrosis, and the one thing we want to review to make sure that we're aware of when we think about hypoxemia is that hypoxemia means that there's a low level of oxygen in the blood. So a decreased oxygen saturation of hemoglobin in the arterial blood. And all of these causes lead to that situation. So when we are thinking about hypoxemia and the way you want to organize your diagnosis for hypoxemia and what might be causing the hypoxemia, we usually lump things into 4 different categories. Those categories are low levels of alveolar oxygen, impaired diffusion, so an impaired exchange over the alveolar membrane or between the capillaries and the alveolus in the lungs. Number 3 is an impaired oxygen binding to hemoglobin. And then number 4 is something called Vq mismatch, where V stands for ventilation and Q stands for perfusion, and that's the air coming into the lungs and blood coming into the lungs, and those not matching up as nicely as they would in normal physiology. When we think of low levels of alveolar oxygen, and here's a hint, we talked about it a little bit earlier in the pulse oximetry section, can you think of 2 etiologies or 2 causes that lead to low alveolar oxygen? Go ahead and use the chat box for this one as well. So what causes the air in your lungs to be less than the normal amount of oxygen that you would normally see? Yeah, some good answers in there. So the one that we had mentioned earlier is that if they're living at a high altitude, for example, I live in New York City, so I'm living at sea level. And if I go to the mountains, the amount of oxygen that I see in the mountains is going to be a lot lower than I'm used to in New York City. So my alveolar oxygen availability is going to be a little lower. Another one that people were talking to or mentioning is hypoventilation. So apnea, where you're not breathing at all, or things that might be preventing you from breathing very quickly. If you're septic, for example, sometimes your respiratory rate can go down, or if you have an effect of certain types of drugs, like an overdose of opioids, your respiratory rate can also go down. And that means the oxygen that your lungs are seeing from the air is not what it normally is. And so these can cause hypoxemia. Next, we're gonna think about this other question. What type of poisoning leads to an ineffective binding of oxygen to hemoglobin? And in what settings is this type of poisoning a risk? We've got some good answers coming through, some carbon monoxide poisoning, fires, asphyxiation, certain types of drugs. Yeah, so this harkens back to more of very basic sciences about how oxygen binds to your hemoglobin. And the one that we're going to focus on here is carbon monoxide poisoning. So carbon monoxide is a byproduct, as someone had mentioned in the chat, of incomplete combustion of a fuel source. And when you have carbon monoxide, it binds much more tightly to your hemoglobins than oxygen can. So it sort of takes up the space where oxygen will normally bind to your hemoglobin. So your blood cells and your hemoglobin isn't able to distribute oxygen the way it normally does. Looking at this resource here from the Mayo Clinic, many devices that rely on a fuel source like space heaters, indoor cooking ranges, fireplaces, those kind of things, if they're in a place that is not adequately ventilated, it can cause a buildup of carbon monoxide, and which can and then in addition to your sort of situational risk factors, you have these risk factors around the types of people that are exposed to it. So if you are pregnant and have an unborn baby, that unborn baby is really susceptible to carbon monoxide poisoning. Young children, they breathe at a higher rate than adults, so they're breathing in more of the air, so they are more susceptible as well. You have older adults that might have other pre-existing conditions that make them more at risk for carbon monoxide poisoning, leading to some brain damage. And then there's also people that have chronic heart disease, chronic lung disease. They're just a lot more sensitive to exposure to carbon monoxide. It can have bad effects from it. So nicely done, everybody. The next topic that we're going to brainstorm and think about is, I think, the most expansive category that can cause hypoxemia, this VQ mismatch between your ventilation, so the air that comes into your lungs, and the blood that's going to do gas exchange in your lungs. Any 4 common causes that in pediatric patients that we can think of that causes VQ mismatch? We can use the chat box here to put in some options. Yep, sometimes people are used to referring to this VQ mismatch as a imbalance between your dead space and your shunting. So we've got pneumonia, drowning, interstitial lung disease, airway obstruction, so your obstructive airway diseases, cystic fibrosis, another big one, emphysema, pneumonia, a pneumothorax, congenital heart disease is another one. So the big ones that we think about in our pediatric population, as of course we've mentioned before, is pneumonia, aspiration is another one, congenital heart disease, and asthma. These are big things that you want to make sure you rule out in your patients, as they're the most common causes of VQ mismatch. Again, VQ mismatch is your ventilation, that air lungs, and Q is the perfusion, so the blood that's coming into your lungs to exchange those gases, to offload carbon dioxide and to pick up oxygen. And so the biggest cause is pneumonia. Remember that pneumonia is an infection of the lower respiratory tract in your lungs that's caused by viruses or bacteria, and is the most common cause of hypoxemia in children. The infection in the lungs can cause fluid to build up in the lungs and infectious material in the lungs that impairs your lungs' ability to exchange gases. And remember, you usually treat pneumonias with anti-infective agents. If it's caused by bacteria, then with antibiotics. If it's viral, then you usually are just supporting them until the virus runs its course. Aspiration is another big cause in children. You can have aspiration at birth with meconium. You can have drowning or even aspirate stomach contents. And this causes an acute inflammatory reaction in the lungs of adequate perfusion of the lungs and also adequate gas exchange. Asthma is another big one that we're seeing more and more in children. It's an obstructive disease where the little small airways tighten up and they can't get air in and out of the lungs as easily as they normally do. And then there's also congenital heart disease, where sometimes it goes unrecognized for a little while. You'll see it in patients that are refractory to oxygen therapy and have these low pulse ox readings. And usually these defects are noticed later by listening for a heart murmur when you're examining the patient. And they include septal defects between the atria or the ventricles, tetralogy of Fallot, or persistent fetal circulations that don't close. These usually need surgical corrections to be completely corrected. But remember, all of these are treated initially with oxygen right off the bat. So thank you.
Wonderful, Justin. Thank you so much. Great explanations, excellent teaching. So an update on our patient. So our patient remains tachypnic, stable nasal flaring, and intercostal retractions. But now we have a little bit more information from the laboratory and as well as from chest x-ray. So white blood cell count is slightly low at 2,000. Platelets are also low at 110,000. C-reactive protein is elevated at 30, and erythrocyte sedimentation rate is elevated at 80, pretty significantly high. Chest x-ray shows bilateral multifocal ground glass and consolidated airspace opacities, as well as cardiomegaly and bilateral pleural effusions. So our little patient is quite sick. His chest x-ray is significant for signs of ARDS even, in addition to this cardiomegaly and bilateral pleural effusion. So because of the information we just received, we can narrow our differential diagnosis a bit. Disease, foreign body aspiration, most oftentimes is not going to cause the chest x-ray findings, CRP, ESR elevation that we have. Yes, somebody just put in the chat CHF, absolutely. Does look like that picture. As well as COVID-19 is a possibility, severe pneumonia that has led to ARDS, congestive heart failure, multi-system inflammatory syndrome in children would be the ones that would really remain high on my list of differential diagnosis for this child. And so with that, bearing that in mind, we want to go to the clinical exam and find out what is going on with this patient's clinical exam. And Dr. McFadden will cover practice change objectives with the goal of recognizing hypoxemia during clinical exam of pediatric patients, understanding diagnostic considerations for pediatric patients with hypoxemia. And I'll turn it over.
Hello, everyone. My name is Grant. I'm a pediatric anesthesiologist at Stanford University. I'm an African. I'm from South Africa. And although I'm working in the United States right now, I really look forward to returning to Africa. So shout out to all my fellow Africans. First of all, in this section, let's watch a little video of a little child. It's a short video. Let's watch this, and while we're watching it, let's list a few signs that we see that are associated with respiratory distress and hypoxemia.
asthma. It said C, C. Well, it just says C medical card.
So what signs of respiratory distress do we see in this little child? Here's someone's spotted nasal flaring, which can be a little difficult to see in this video. Children have very soft, compliant chest walls. So we see intercostal and subcostal recession, the chest wall drawing inwards. We see that he's breathing fast. He's tachypneic. We see some seesaw breathing, thoracoabdominal dissociation, otherwise known as seesaw breathing. His abdomen and his chest are going in opposite directions. Those are all very good answers. Yes, he's breathing fast, rapidly. So we'll carry on with the resource from the World Health Organization. This is an excellent resource. And the WHO makes two strong recommendations when we are examining a child with respiratory distress. So the first recommendation, which we've touched on already, is to use pulse oximetry to detect hypoxemia. Not two pulse oximeters, but they are becoming more widespread around the world. And pulse oximetry really is the most useful way that we can detect hypoxemia, and the most accurate way that we can detect hypoxemia. And we're going to go on to discuss why this is, why it's so important to have access to pulse oximeters, if at all possible. So we'll move on to the second recommendation, which is clinical signs. Which clinical signs are the most useful? So we can read there, it says number 2A, to use pulse oximetry whenever possible. And that's a very, very strong message from this webinar, because pulse oximetry is just so useful in detecting hypoxemia in children. But if oximetry is not available, or our pulse oximeter is not functioning well, we need to use clinical signs. And we can see the clinical signs listed there under 2A. Central cyanosis is the most useful clinical sign. We're going to talk about that a little bit later. As we noticed with that little child, there was some nasal flaring. Another useful clinical sign is the inability to drink or feed in a baby. They can just be too tired, too obtunded to drink or feed, or they could just be working too hard to breathe to be able to suck, and in an older child to be able to swallow. And that's very worrying if a baby or a child just stops drinking or feeding, or takes less breast milk or bottle milk. Another clinical sign is grunting, when a baby especially grunts with every breath. what are they doing? Can someone throw it out in the chat box? What are they doing unwittingly when they're grunting, when a baby's grunting? What is he or she trying to do? So what the grunt is doing is, there it is, there the answers are coming up. They're generating PEEP, that's correct. So that's what that grunt is doing, is it's trying to generate PEEP. And what we know is that PEEP is trying to open the alveoli and keep those alveoli open and improve the VQ mismatch. So in other words, improve delivery of oxygen to the bloodstream. You guys are really, really good. Yeah. Another very worrying sign is depressed mental states. In other words, drowsiness or coma. So if a baby or child is getting drowsy from a respiratory cause, that's a very strong sign that they are going to be hypoxemic and that they'll need oxygen. And then 2B, in some situations, there are less specific signs, but these signs could also mean that babies and children are needing oxygen. So if they have severe retractions, especially of the lower chest, so sometimes these are referred to as subcostal retractions, that can be a sign that they're needing oxygen. And that's a more useful sign than intercostal recessions, so between the ribs, or suprasternal retractions. So it's really the lower, when you see the lower chest being drawn in, that's a worrying sign. And then when they're breathing very, very fast, so above 70 per minute, this would be in the lower age range, between 2 months to 5 years old. Babies do breathe fast anyway, but above 70, if you see a baby or a young child breathing more than 70, it's likely that they need oxygen. And then the other sign is head bobbing or head nodding. If a baby's lying on their back, they're using their accessory muscles of breathing, so their strap muscles in their neck, and they're working so hard to breathe that every time they take a breath in, their head nods, and that's another sign that they may be hypoxemic. And so just to review, let's throw it out there. What are the major challenges that we face when examining a child for hypoxemia? So in other words, what makes it really difficult to know if a child is hypoxemic if we don't have pulse oximetry? Yes, it can be very difficult to detect central cyanosis. We need to look at the mucous membranes and the tongue rather than at the lips to detect cyanosis. And if we're trying to look for cyanosis under ultraviolet, fluorescent lights, the ultraviolet radiation can make the skin or the lips look blue. And so we need to remember to examine under sunlight or an incandescent light bulb, a normal light bulb. There's a very important point, is that little children can't talk to us and tell us how they're feeling. And children tend to not be complainers as much as perhaps adults are. And so it's difficult for them to express to us how they're feeling. And the first time we know that they really are in trouble is when they become drowsy. And as we said, once a child becomes drowsy, that's a very worrying sign. Non-cooperative patients, children can be very difficult to examine. They can be crying, so it can be difficult to auscultate with a stethoscope, and so they can be more challenging to examine than adults.
All right, wonderful. Thank you for those exam findings. And it's very, very important to be able to obtain an accurate and adequate pediatric physical exam. So now in our patient, he weighs 20 kilos. He is ill appearing and drowsy, but is arousable and in moderate distress. He has bilateral conjunctivitis, but no discharge or scleral icterus. He has mild periorbital edema without erythema and nasal flaring. His mucous membranes are slightly dry. His mouth, his tongue is swollen and is red, strawberry color. Chest-wise, he has increased work of breathing with accessory muscle use and intercostal and suprasternal retractions. He has crackles at his bases bilaterally with intermittent wheezing and prolonged expiratory phase. No stridor and good air movement. His PMI is in the left mid-axillary line in the 6th intercostal space, suggesting that it's enlarged. He has tachycardia with a regular rhythm. He does notably have a positive S3 gallop, but no murmurs, rubs, and his pulses are diminished in all extremities with a increased capillary refill greater than 3 seconds. His liver is enlarged as well, and he has non-pitting edema in his hands and his feet. No cyanosis is appreciated, but he does have palmar erythema bilaterally with poor skin turgor and mild tinting. I love that. You guys are giving some great possibilities of answers in the chat. That's wonderful. We'll go back to Dr. McFadden, who will discuss the emergency signs requiring intervention.
So before we move on to the diagnosis, when we examine a child, there are some signs that alert us to a child being very sick. So in other words, we need to intervene immediately and save that child's life. Which signs would be emergency signs that would require us to let's have some suggestions. Lethargy, drowsiness, yes. Unresponsive would be extremely worrying. Severe respiratory distress, fever, seizures, particularly if they're prolonged seizures. The red box this is from the WHO. We can see the WHO lists these emergency signs. So if we have upper airway obstruction, so that's the breathing is obstructed, or absent breathing or apnea, we'd obviously need to intervene immediately to open the airway or support the respiration, because otherwise that's apnea and then lead to cardiorespiratory arrest. Severe respiratory distress, we've talked about the signs of severe respiratory distress, is an emergency sign. Central cyanosis, so if you can detect that there is central cyanosis, that requires immediate intervention. A child that is shocked, so cold hands, a capillary refill time of more than 3 seconds. If they're tachycardic, and especially with a weak pulse, and it's very low or unmeasurable, that child requires immediate intervention. If there is coma, a new onset of coma, or a seriously reduced level of consciousness, if they've been convulsions, especially if they've been prolonged convulsions, and then in a child with diarrhea, so if that child is brought in and the child is lethargic, if it has sunken eyes, or very slow return of the skin after pinching, those are signs of a very sick child that needs immediate intervention. We come on to another question. How can healthcare providers distinguish between respiratory distress and respiratory failure? Anna, do we have time to watch the 4-minute video, or shall I just cut to the chase with that one?
If you don't mind, Dr. Mafadjian, just cut to the chase. Thank you.
Okay. So we've been talking about respiratory distress and the signs of respiratory distress. And respiratory distress can lead on, and the most important message, let me ask that as a question. What is the one thing that really tells us that a child has progressed to respiratory failure? So the child's in respiratory distress and severe respiratory distress, but what's the most worrying thing that tells us that that child is decompensating? Because we know that during respiratory distress, the child is compensating and is still able to breathe, has lower oxygen levels, but the carbon dioxide levels are going to be increasing. And if we did do a blood gas, we'd see that their carbon dioxide levels were increasing. And as they progress into respiratory failure, the carbon dioxide levels increase even more. And that leads to something that is very alerting us that this child may be close to getting respiratory failure and stopping breathing. So yes, someone has said hypoventilating. So when the breathing's slowing down, but something's going to happen to that child as they progress on to respiratory failure. And what it is as their carbon dioxide levels increase, that acts to sedate the child. There we go. Someone's just said impaired arousability, decreased level of consciousness. Thank you. Those are the answers that I was looking for. CNS signs. So once the child becomes drowsy, unconscious, that child is close to having a respiratory arrest, and that can lead to cardiac arrest. So that's when we have to step in and really save that child's life.
Thank you, Dr. McFadden. That was wonderful. We're now going to advance on to therapeutics and interventions, with our practice change objectives being prescribing oxygen therapy for pediatric patients, implementing for pediatric patients with hypoxemia. I'll turn it over to Dr. Quincy.
Hi, everyone. I'm Maria Quincy. I'm a resident based here in New York City as well. Thank you to everyone for being here today. It's been incredible to be part of this session. So we'll jump right into how we address these issues of hypoxemia in the pediatric patients. So like when approaching any patient, we really want to start with the basic regular ABCs of any intervention. So first and foremost, obviously, you want to open the airways. We've discussed pulse oximetry and its availability, as well as the other means that we can use to try and assess for oxygen status, as well as the potential oxygen therapies that are available as well. Again, we want to suction as necessary, just as we would in any adult patient as well. And initially always required for pediatric patients. If the child looks to be in respiratory distress, and if that is available to you at your facility, that is certainly additional information that is beneficial to have. And I think Dr. Murray is going to jump back in here with a case update.
Yes, so clinically our patient a little bit improved. He got a 20 ml per kilo normal saline bolus. He was started on empiric IV antibiotics, and he received paracetamol therapy. So now his blood pressure is slightly improved with a MAP, or a mean arterial pressure, of 55. And his temperature is also slightly improved, although he is still febrile. And I'll turn it back over to you, Dr. Quincy.
Great. So just to dive here into how to tie together our previous discussions of some of these signs and symptoms of hypoxemia with the administration of oxygen and other therapeutics, and how to stratify these presentations. We use the Pediatric Advanced Life Support algorithm, which helps classify pediatric respiratory emergencies by type into the 4 categories of upper airway obstruction, lower airway obstruction, disordered work of breathing, and lung tissue disease. So to look first at the classic clinical pre-obstruction, which usually includes stridor, also known as high-pitched, noisy inspiratory breathing. I just want to ask you all a question of what are some common etiologies of upper airway obstruction? Foreign bodies, I'm seeing excellent. Croup, excellent. Enlarged tonsils, epiglottitis. Just a few more seconds, perfect. So in the in the chat session here. We can break down that differential for upper airway obstructions in between infectious anaphylaxis as well as foreign body obstruction. Obviously, there's certainly more components to each of these, but the primary ones that we see, as people have touched upon, is croup, which is an infection of the upper airways caused by multiple different viruses. It causes swelling of the larynx, trachea, and bronchi, as well as, in addition to the stridor, a very characteristic barking cough. Our primary treatment modalities for that are going to be nebulized epinephrine and epiglottitis as our kind of other main infectious etiology is that swelling specifically of the epiglottis, most often linked to Haemophilus influenza. It also, in addition to the stridor, presents with trouble swallowing, drooling, fever, changes to the voice, as well as an increased respiratory rate. The anaphylaxis, which is the swelling of the upper airways, but can also extend into the bronchioles as well, causing some bronchospasm, usually presents with some angioedema as well as a rash. And thank you for pulling up the algorithm here, Dr. Crawford. And the primary treatment modalities here for anaphylaxis are epinephrine delivered IM, as well as albuterol, antihistamines, and corticosteroids. And the treatment plans are really targeted towards helping to decrease that inflammation of the airways to try and increase the lumen or the diameter of the airways to help improve airflow and oxygen flow as well. In terms of the last group here of foreign body obstruction, we know that often, as I think Dr. Genziano touched on, children are putting things in their mouth. These are usually present either with the child self-reporting or with a witnessed event, but can also be presenting later after the fact with fever, trouble swallowing, drooling, as well as refusing food ingestion. And ideally, if it is a recent or witnessed event, we can try and administer a Heimlich maneuver, or we can also try and optimize the patient's positioning. And should it, have been passed too far distally at this point, we do need to get a specialist involved, ideally an ENT or a gastroenterologist who can help us with being able to retrieve that object. So we're going to jump into our next question here for all of you, just to make sure that we caught all of those interventions. So which of the following interventions are effective in relieving upper airway obstruction? And I can read out the options as well. There's a headrest and placement of a shoulder roll, nebulization of epinephrine for croup, steroids for epiglottitis, Heimlich maneuver for foreign body, suctioning for secretions. All of the above might be utilized depending upon etiology of upper airway obstruction. And we've got some great results coming in here. So it looks like 92% of you are all recognizing that each of these modalities might all be useful for treating one of those types of upper airway obstruction. So it's very helpful to help categorize each of them in order to try and target your treatment plan effectively. And then I just want to dive here into some differences between the pediatric airway and the adult airway, and partially why those goals of trying to decrease the inflammation, both with the epinephrine and the steroids, and really increase the diameter and the opening of the airways. So again, we're doing that both by vasoconstricting with the epinephrine as well as by relaxing the bronchioles, both with the albuterol and other beta agonists as well. But just to give a visual representation of the differences between the pediatric and the adult airway, and you'll see this is the pediatric airway on the left and the adult airway on the right. But the considerations that help dictate the care for us is that in a child, the epiglottis here is a lot floppier and it's much more U or omega shaped than the adults, meaning that when it gets inflamed like that with epiglottitis, that has a much greater potential to cause obstruction than with an adult. Additionally, the child's airway is much more anterior and it's higher up here. The narrowest point for a child is here at the cricoid. If you want to point that out, Dr. Crawford, versus here on the left on the cricoid versus at the vocal cords in the adults. And those anatomical differences results then in this kind of cone-shaped difference between the pediatric airway as well as compared to the more cylinder-shaped adult airway. That kind of difference in the shape of the airway, and again, our pediatric patients for the most part are much smaller again than our adult patients. So again, we're already dealing with a much smaller diameter, a much smaller radius of the size of the airways, so it's much easier for it to be obstructed. The main equation that we use in order to guide our understanding of airflow is an equation called Poussey's law, which governs airway resistance, and it tells us that the resistance of an airway is proportional to the length of an airway and inversely proportional to the radius to the power of 4. So what that really means is just any change in the radius of an airway is going to have really profound implications for the resistance and for air to pass through. So we can jump ahead then to how to really try and optimize that positioning so that we're really getting as much airflow through as possible. And again, this is something because of those anatomical differences between the adult and the pediatric airway that we see very different implications for our positioning as well. So because of that more anterior placement, when we're putting an infant in a sniffing position, we really want to make sure that we have a shoulder roll in place as well as a headrest. And we want to try and horizontally align that chin as well as in that sort of straight alignment as depicted here. And our neck, we really want to try and optimize to make as wide open as possible. And then we want to try and target our external auditory meatus here, right at the position here of the neck as well. So we can jump ahead then here as well. So we're just going to jump into lower airway obstruction now. So that's going to be our second category that we talked about. So our classic description of the clinical presentation of lower airway obstructions includes expiratory wheezing. So the two most common etiologies that we see are asthma and bronchiolitis. Again, just before we jump into the therapeutics, our asthma does comprise, so as we're moving down the airways, we talked about upper airway obstruction and upper airway constriction. Asthma and bronchiolitis both are consisting of narrowing of the airways further distally and are due to mucosal inflammation and smooth muscle hypertrophy. And just as we discussed with Poussey's law, we still have that decrease in that constriction of the diameters here. So instead of the upper airway being constricted, now we're concerned with the bronchioles and that are also being constricted. And it's due to an increase in smooth muscle tone. So we get a sort of turbulent flow from that airflow that then results further in that kind of characteristic wheezing sound. And you can imagine kind of in a sort of narrow constricted airway, having air molecules bouncing back and forth and creating a sort of turbulent flow, giving a wheezing sound when it passes in and out. So we're going to jump here into the question, which it looks like some people have already started to answer, but it's to read out loud is just which of the following interventions should not be utilized to relieve lower airway obstruction. And everyone's doing great. We're already seeing that, yes, aggressive fluid resuscitation should not be used to relieve lower airway obstruction. The accepted modes of treatment are just as we were trying to relieve that obstruction and open up the airways, bronchodilators and corticosteroids are both very beneficial for helping to open up the airways. And again, we've pulled up a great image here showing, we're not only starting with a much smaller tube here in the pediatric or infant airways, but then we also see the profound effect that having the edema then decreases that area. And then this, based on Pousset's law, we get a proportional decrease in the cross-sectional area as airway passes. So our third category is going to be disordered work of breathing, and that comprises the different problems, including seizures, intracranial pressure increases, and neuromuscular diseases such as a C-spine injury, phrenic nerve injury, myasthenia gravis, Guillain-Barré, as well as overdoses and poisonings, including opioid overdoses. So if anybody wants to comment on what our treatment guidelines can be for this variety of groups. They usually present with slow respirations or disordered control of breathing, as well as lethargy or cyanosis and hypotonia. Great, so I'm seeing CPAP, BiPAP, non-rebreathing masks. Assisted ventilation, correct. Great. So the other way that we can think about this as well is just in terms of our targets. And I know this came up in some of the prior questions, but we're trying to support breathing and respiration. So we're trying to avoid hypoxemia. We're trying to avoid hypercarbia, as well as avoid hyperthermia. As the chat touched upon, certainly we can provide ventilatory support if applicable. So we really want to be able to kind of quickly jump in and administer oxygen either with nasal prongs, as well as bag mask ventilation or an advanced airway like an endotracheal tube if that's necessary. Additionally, if we are concerned about overdoses or poisoning, including the carbon monoxide poisoning that was discussed earlier, we want to be in touch with our local poison control center for if there is a specific treatment. However, a lot of this is going to be supportive therapy and just to help get patients through the acute phase here. And then, so the antidote to opioid poisoning that I'm seeing the question come up here. And again, with infants, we're concerned, and children, we're concerned either about their own ingestion or in terms of infants, maternal ingestion of opioids. So you can have infants that are born and presenting with signs of either an opioid overdose or then withdrawal. But our primary means, other than being able to support a patient ventilatory support through it, is an antidote called naloxone or Narcan, which is becoming more widely available, but it is a specific antagonist to opioids. It does work very quickly, so it's a very fast onset and fast offset. So if a patient has had an overdose, you want to make sure that you're continuing to administer naloxone and you're continuing to monitor rather than doing a single dose. And I'm seeing flumazenil as well, which is also an antidote to a benzo or a benzodiazepine overdose, and that is more specific to that. And then lastly, we want to just discuss briefly, just before we jump back into our case, but the disorders of the lung tissue. So those characteristically present with crackles, rhonchi, dyspnea, tachypnea, which, as we're seeing in our case patient, is most likely what they're the category that we're dealing with here. And there's two main disorders to consider under that characterization. Those include pulmonary edema as well as pneumonia. And again, pneumonia is based on an infectious etiology, whereas pulmonary edema can usually be a marker for another process that's going on, including a heart failure. And for both of those, well, with pneumonia, you obviously want to treat the infectious etiology as well usually with antibiotics. But both of those also, we can consider ventilatory support. And I know, as we've discussed today as well, we can certainly consider PEEP to help maintain the patency of those alveoli and of the airways by providing that positive end expiratory pressure. And for both of these etiologies, sometimes we do also have to help support their blood pressure as well with vasoactive medications. And in pulmonary edema, we would administer some diuretics sometimes as well to help offload some of that fluid that is impairing that VQ matching that we discussed earlier as well.
Wonderful. Thank you so much, Dr. Quincy. So just an update on our case. Additional interventions that have been given. Dopamine was started at 5 mics per kilo per minute. Unfortunately, the hospital did not have norepinephrine in this case scenario. And epinephrine was also in scarce use. Additionally, the patient was placed on high flow nasal cannula with a flow of 10 liters per minute and an FiO2 of 60% to help increase PEEP for this patient. Vitals were essentially unchanged except for the respiratory rate improved. The blood pressure also improved and the SpO2 improved. Exam-wise, there is not a huge difference in exam except for his respiratory appearance on exam was improving. His intercostal retractions were now mild and there was resolution of the suprasternal retractions. His capillary refill was also less than 2 seconds, which shows an improvement from the dopamine and the fluids that were given. So what is this child's diagnosis? This child has a diagnosis of multisystem inflammatory syndrome in children. The diagnostic criteria for this is an individual less than 21 years old that presents with fever. And in general, that fever days or greater. Laboratory evidence of inflammation, which we saw with the elevated C-reactive protein and ESR. And evidence of clinically severe illness requiring hospitalization with multi-system organ involvement. In our case, he had cardiac involvement and he also had respiratory involvement. Quite likely he had renal involvement as well, and due to decreased perfusion. There's additionally, in addition to that, you also have to have no alternative plausible diagnoses. And lastly, there must be a positive current or recent SARS-CoV-2 infection diagnosed by RT-PCR, serology, or antigen test. And then finally, the other option is that maybe they had negative, like this child, he had a negative SARS-CoV-2 lab work, but he had an exposure within the past 4 weeks of onset of his symptoms. And that is what really placed him in this category. We have seen children recently with this. There have been several that have been admitted with family members in their household who had COVID-19. And then these children presented in this exact same manner to the hospital. Therapy is mainly supportive. They're going to need ICU care. So you should really, when you see these kids, be prepared to transfer them to a higher institution. Give aspirin, IV, IG, steroids, and biologics. But this is also needs to be, you have consultants on board, such as cardiac and rheumatology if possible. And we'll give you some great resources additionally that you guys can look into.
Thank you, Dr. Murray. Yeah, we definitely need to be on the lookout for this diagnosis during the SARS-CoV-2 infections going up with COVID-19. So we're seeing more and more of this. I just want all the learners to know that we have several other additional resources listed on the Learning Resource Center. There's a really great anesthesia tutorial of the week that was put out by the World Federation of Societies of Anesthesiologists, and it talks about critical SARS-CoV-2 in children. There's also PICU or pediatric ICU guidelines for both high and limited resource settings, and those are available on the Learning Resource Center. Another great resource that we love is opencriticalcare.org. They have a guidelines dashboard, and they also recently released many videos about caring for pediatric patients, specifically with airway and oxygenation concerns. There's other guidelines on the WFSA website, on the UCSF website. They have another MISC guidelines for children and some other clinical guidelines and protocols for COVID. There's also the US National Institutes of Health, and another great website that we love for adults and pediatric patients is this covidprotocols.org. So for more information about any of these diagnoses and more information about COVID in children and just oxygen therapy in children, make sure you check out those additional resources. So the Learning Resource Center, we shared the link earlier in the session, is open access, free, and available to all. So anybody can sign up for an account and access all of these resources. In addition, there are some things that you can download. We have slides that are available for download. We have the WHO Oxygen Therapy in Children available for download. We also have the WHO UNICEF technical specifications for oxygen that Dr. Reddy discussed. And all of those things are available for download, and the links are also available in the chat. I want to give a really special thanks to all of these amazing panelists. I'm an adult anesthesiologist and an adult ICU physician, so I could not have put this together without the help of my brilliant colleagues. So really want to thank all of these wonderful, wonderful panelists. And most importantly, thank you to all the learners. You guys are really impressive, and we're super happy to have these discussions and share all of this knowledge with you. And as most of you know, we like to end with some inspiration. So we have a Chinese proverb that states, if you're planning for a year, sow rice. If you're planning for a decade, plant trees. But if you're planning for a lifetime, educate people. So with that, we will end our session. And again, huge thanks to all of you for joining us.
Hello. To wrap up the session, we do have a couple of notes. The link to the Learning Resource Center is in the chat. And we encourage you to use this resource to access slides, recordings, additional resources, quizzes, case exercises, and videos. To obtain a certificate of attendance, fill out a short feedback survey. These in the chat and are available in multiple languages. And a link to the recording, Learning Resource Center, and the feedback surveys will all be shared after the session by email. We also have a very active WhatsApp group. If you would like to join it, please scan the QR code on the screen. We will also share the link in the chat. And then just to wrap up, we'd like to say thank you to our funders at Project Echo for making this program possible. Please save our next session date in your calendar. The topic will be considerations for obstetric patients, and the session will be taking place on Monday, May 24th. So we hope to see you then.